This is the Something to Talk About program, which we do several times a week here at the Bainbridge Island Senior Community Center. And we are grateful for sponsorship from Fieldstone Memory Care of Bainbridge Island, which offers innovative and compassionate care. And they are now accepting residents as well as day stay and respite programs. To learn more, call 360-689-4314. I also want to thank Dr. David Cowan, who is here today to talk a little bit about the topic we have been talking about for 2 years now, which is COVID-19, which it's now COVID-22, I guess. And we keep seeing varieties of the virus circulate and the numbers fluctuate. Fortunately, the virus has been somewhat abated by powerful vaccines, but it has not been stopped by any means. So I really appreciate you coming by, Dr. Cowan. You're the one of the co-leaders of the Medical Reserve Corps as part of Bainbridge Prepares, and Bainbridge Prepares is one of the organizations that has been helping to keep us vaccinated. So thank you for that.
Sure.
I really, I know that there's probably more unknown than there is known about the virus, but I'm guessing that we know more about COVID, at least in terms of transmission and how we might be able to eventually turn the corner than we did. Unfortunately, we don't know quite enough yet, right?
Yes, I think that is right. I think that you kind of captured, I think, the essence of my message, which is going to be that vaccination has been phenomenally effective at preventing severe disease. We do not yet kind of grasp the technology needed to prevent circulation of new variants of COVID. And I think you're right, it does remain to be seen what the solution is going to be. I think there are a lot of people working on it. And, I think there are some sort of intermediate steps that look like they're in the works, probably a 1.5 or 2.0 vaccine. Both Moderna and Pfizer have applied for emergency approval for a vaccine that would include the Omicron capsule proteins as antigens in addition to the original variant. Of course, the vaccines that we're using currently are all just the original variant protein.
But you would recommend even getting a booster of this vaccine that is targeted to the original variant?
I think for most of the senior center folks that are likely to be tuned into this, I think that does make sense. I think that the message is a little bit more nuanced for, the kind of the general public or my patients as a whole. The second booster is approved in the United States for those 50 and up. And whether, and interestingly, that's not the case in Europe. I believe Germany approved the second booster only for 75 and up. I think that there are a lot of questions about using that second booster in people, I would say, younger than 75. Partly because the data that decision was based on, I don't think has been published. It was collected in Israel, and I believe through some kind of arrangement with Pfizer, Pfizer owns that data. It isn't publicly available. It wasn't published in a peer-reviewed journal, and the Vaccine Advisory Committee was not asked to review it, nor were they asked for their opinion. But that said, and I should just say while we're talking about the Israeli data that, it showed that a second booster of Pfizer BioNTech vaccine produced a dramatic reduction in hospitalizations and deaths in patients older than 65 from the first Omicron variant. I have to say I'm not seeing a lot of hospitalizations and certainly not deaths from the Omicron variants, but and again, it's kind of hard to comment on that data, obviously, since it's not published. Obviously, when you look at data from any study, you're particularly interested in, who's the control group? Are the groups really comparable? Did more mobile, healthier 75-year-olds or 65-year-olds go and get the vaccine, and the homebound, more ill older patients not get the vaccine? Of course, that would skew the results. So that's the kind of thing you really like to be able to see by reviewing the data, in a kind of standardized form. But,
so you're still leaning toward, maybe partially because of the evidence or the information you've learned,
well,
sort
I think,
of secondhand, that for 65 or 75-year-olds,
certainly for 75 and older. I mean, well, the top group obviously is anyone with, multiple chronic illnesses and immunocompromised. Obviously, that's a no-brainer. They should be getting the second booster. My personal sort of synthesis of the information is that those over 75, out of an abundance of caution, even if they don't have multiple other diseases and immune compromise, probably, it's just, I think, prudent and very unlikely to produce any harm. And I suppose the same could be said for those 65 and older, if you're kind of following the Israeli data. For those between 50 and 60 or 50 and 65, if they're otherwise healthy, yeah, I'm really not so sure about that. Even Dr. Jha, the current COVID czar for the US, said that that's kind of a personal decision. There really isn't any data.
So it's basically, without any real data, it's not, well, I'm trying to figure out whether you think there's a risk to people taking it, or if it's,
no, I really don't think there's a risk. But, I think it's important to sort of think about, a little bit about the immunology of the vaccines. And to me, what I've seen is that sort of a little bit of review. We perhaps covered this on an earlier Zoom call, but for those of your senior center participants who aren't retired immunologists, the immune system has two main parts, T cell and B cell immunity. In my view, there's good evidence to show that the vaccines have produced phenomenally robust T cell immunity. Now, T cells really, I think, are what protect you from having severe disease, needing to be in the hospital, potentially dying. And the T cell system is, not only does that immunity appear to be robust, but the T cell system has phenomenal sophistication, I would say, in that it has a built-in gaming program where the T cells themselves are rearranging the antigen, and kind of like going to the casino and trying to bet what the virus might be doing in terms of shape-shifting. Now, the B cell system, that's the part of the immune system that produces antibodies. And it is not quite, I don't think it has the built-in casino gaming. So it basically is in response to either an infection or the vaccine, it's producing an antibody that is kind of lock and key with the the protein configuration of the virus capsule. And we call that configuration of proteins the antigen, basically the target of the antibody. But the problem is that, the vaccine that we're using is for the original variant, and there are something like, 50 deletions, 50 changes in the protein configuration of the Omicron variants. And that's enough of a shapeshift that the lock and key system is not, it doesn't quite fit the lock exactly. And so that, I think, is part of why we're seeing, reinfection or infection after vaccination, even in people who have been double boosted. And again, as we sort of touched on at the top, what the solution for that going forward is still to be determined, because it would involve having some type of antibody response that is like broader or more flexible or somehow anticipates a future variant. So that's why I kind of called the vaccine that Pfizer and Moderna have applied for as kind of a 1.5 vaccine. It includes the Omicron capsule protein configuration and the original variant. But, if there's another new variant, that's not going to be a part of that vaccine. And yeah, I'm not exact. Yeah, we can talk a little bit about what other solutions might be, but it's getting to the edge of my understandings, because even for immunologists and molecular biologists, I think this is an unanswered question. But kind of going back to the summary of the vaccines that we have, I wanted to highlight some data, and I was actually going to put it in the chat, if that's okay. I'm not sure everyone knows.
Yeah, we can. Yes, we can. And I can also share it afterwards in a text file linked to the video.
Okay, well, it isn't. Well, let's see. Maybe I should then. Okay, well, then I'm going to cut and paste.
Unless you don't want to share a screen, right?
I don't really need to.
Okay.
I don't really need to, but let's see here. And it's basically just a snippet summary and a link to the original article. But I really thought this was an impressive kind of summary of what I've been reviewing with you, at least the effectiveness of the current vaccines. And it's from an MD epidemiologist that I follow at UCSF. Her name is Monica Gandhi. Some people may have seen her on television. She's become quite popular, but I also think she's very bright and really has a very solid understanding of the immunology. So there is the chat link. So she summarized here a report from the CDC, and it's about Delta. The data, published data, really lags behind what's going on currently, because it takes a while to collect the data and interpret it. But this was data collected during Delta in patients who had 2 doses of vaccine, which was a full course of vaccine at the time. And the risk of severe COVID outcome was 0.00003%, which is phenomenal.
Yes, exactly.
And hard to even track all the zeros. I don't even know what to call that. It's out so many places. 3 somethings of a percent. I don't, I'd have to take out my abacus or something. And then you can see there's a sentence there that the people who were at risk for severe breakthrough in the US data were people who were over 75 that had 4 other kind of contributing chronic diseases and were immunocompromised. or I think what she meant there is that either they had 4 comorbidities or they were severely immunocompromised, that those were the people that ended up with serious complications. And, as I said earlier, it's a no-brainer that people with that kind of illness burden or immunocompromise should already have gotten the second booster a long time ago. But I think for people who are on the fence, I think there's little harm if you're over 75 or if you're over 65 and just feel like, it would provide you with a little extra. It certainly will boost your B cell immunity. It will give you a boost of the antibodies that lasts about 3 to 5 months. And then they fall back down to kind of a baseline level where, but, I think that what we're observing, what we're all observing, I think, just amongst our friends, amongst our patients on Bainbridge, amongst your relatives around the country, is that, even people who are fully vaccine boosted seem to still be, some of them still seem to be susceptible to the current Omicron variant BA2.12.1 or whatever it is.
Yeah, they seem to, certainly people are testing positive and many people are reporting extreme discomfort. But as you said, they seem to be avoiding, most people seem to be avoiding hospitalization and death. So can we switch a little bit to therapies, to the
Sure.
kinds of things that you now are able to prescribe or at least offer as a doctor that were not present at the beginning?
Yeah. And this is really new, I would say, just in the last 6 weeks. So Paxlovid, people may have heard about. It does appear to be phenomenally effective at reducing the risk of serious illness. And it's really available. Basically, the US government bought all the available doses, at least all the available doses in the United States, and is making it publicly available for free. It's in, I would say, adequate supply, although I did just have a patient yesterday who said that that we sent the prescription to one pharmacy that said they were out of it and they needed to switch the prescription to a different local pharmacy. So, I think there may be a little more pressure on the supply now that the rate of disease is going up, but it still seems to be, I would say, adequate. And the problems with Paxlovid, well, first of all, I would say, it's an experimental antiviral agent. It's a combination of 2 different antiviral agents. It's very, very easy to take. It's I believe, 1 pill twice a day for 5 days. And it needs to be started within the first 5 days of symptoms or testing positive, whichever occurred first. But the drawbacks are, obviously, because it's relatively new, we don't, know necessarily all of the potential adverse effects. The main issue so far seems to be that it has a gazillion drug interactions. Some of them are quite significant. And I think that has posed somewhat of a challenge, partly because you have to spend a fair bit of time going to internet sites trying to figure out what the drug interactions are. And then the main site we use, which I can post if you're interested, is from the University of Liverpool. And they say right on there, just because a drug isn't listed as interacting with Paxlovid, do not assume that it doesn't interact, which is not very reassuring, because I think there's just limited data. So what they're doing is trying to act as a clearinghouse for reports of interaction as they arise, and rapidly kind of collating that data so that it's publicly available. It's a huge service, and really, really important. But I have seen some cases where, providers who may not be very experienced at prescribing Paxlovid have prescribed it for patients, for example, on blood thinners, and that's an absolute no-go. And fortunately, the pharmacist caught it and did not dispense the drug. And as it really depends on the drug, as you might expect. Someone who's taking maybe a cholesterol lowering drug might be able to stop it for 5 days or a week or two. Someone who's taking a blood thinner certainly should not be stopping their blood thinner without checking with the prescriber, and probably can't stop their blood thinner. So for those patients, there is a new IV antiviral drug, or monoclonal antibody, which is a different approach. And I want to say the name is bamlanivimab, but don't quote me, but I'm happy to look it up if someone wants to know. That one seems to be in scarcer supply for whatever reason. And I had a patient who was at high risk, who tested positive and actually got the prescription for Paxlovid, and then the pharmacist noticed they were on a blood thinner, and then we were apparently able to find this patient the bamlanivimab at a hospital in Tacoma. But that's a much bigger project. I mean, obviously they have to get there, and then it's like a 4 or 5 hour IV infusion with supervision and observation, and so presents more of a challenge for the healthcare system how to do that. Like, for example, we could not, even if we had the drug, we don't have the space and person power to administer, to do that kind of thing in our clinic. For a while, the Kitsap Surgery Center was doing these types of treatments, but I'm not, for whatever reason, they weren't available to do the treatment on this patient, and I'm not sure that they may be sort of getting back into doing surgery and less IV treatment. But Paxlovid is definitely the first option for most outpatients if their drug profile allows it. I think it would be kind of on a case-by-case basis, and it really obviously would require some kind of face-to-face visit, preferably with either, on video, if they're COVID positive, with their provider or someone in their provider's office who could review their medications, check the drug interaction registry, and decide whether it's, indicated. I have a lot of patients who kind of, by the time they get to that visit with me, they're already feeling better. And in some cases, I've written the prescription, but only because maybe it's a weekend. And I said, well, if you start feeling worse, you could go and get it. But a lot of patients are, feeling better in a couple of days and just decide, maybe I don't need Paxlovid. I have heard anecdotally that one patient who completed a course said that he had a terrible, terrible taste in his mouth, which is quite an interesting side effect, kind of oddly similar to the virus itself. But it went away when he, after the 5 days, but it was like to the point where he almost couldn't eat.
Wow.
And
so
then,
go ahead.
The other thing I was going to mention about Paxlovid is these reports of kind of strange, I don't know exactly what to call it, but prolonged viral shedding. So there are reports of some people who, and in that patient, by the way, who got the bad taste, his fever disappeared after the first dose of Paxlovid. So, I think it's highly, highly effective at kind of suppressing the virus. But there are some reports coming out about the possibility that it's suppressing the virus for the 5 days you're on it, and then people start testing positive again after they go off the Paxlovid, suggesting that perhaps it's suppressing it, and then it sort of, bounds back up. Not necessarily that they're getting sick, but sometimes we're giving it with the idea, let's say somebody lives with a person who's immunosuppressed and tests positive, and they live in the same household. So I think some of the rationale, it was, well, let's treat the ill person to try and protect that immunosuppressed person. But there's concern now about this kind of rebound viral shedding and what that might mean. But I don't think we know enough yet.
That kind of gets to my next question, which is about what you're seeing in terms of patient experiences. In other words, is the virus reflaring? There's been a lot of talk about long COVID, so-called long COVID, or a viral shedding that doesn't sort of fit our original view that you had like 4 or 5 days after the end of symptoms and you were probably clean. Have you, in your experience, learned anything more about sort of how those things are playing out?
Well, I don't think there's much, data either pre-published or published. I mean, the official party line is that if you test positive, you can kind of rejoin public life after 5 days, counted from the day of positivity or the first day of symptoms. If your symptoms are improving and you're not having a fever. And of course, you have to wear a mask for an additional 5 days when you're in public. We are also advising people who are sharing a household with somebody who's ill that they consider masking or isolating, in a part of the house where they really don't breathe on each other, because of the idea that viral load may be correlated with severity. And if you can limit the load on the other individual, you might at least reduce the severity of their severity of their illness if they develop COVID. I have heard some anecdotal stories from patients about sort of testing positive and then testing negative and then testing positive again and then testing negative and positive. And I don't know what to make of that, whether that's just sort of the state of our antigen testing. These are all home tests. And that was a patient who did not take Paxlovid. So yeah, cool. I don't know what to make of that. It certainly doesn't fit the official model of how this works. Also, the official CDC position is that patients who are immunized shed virus for a much shorter period of time than those who are not immunized. And I suppose it would also apply to patients who have had a prior infection, which is really mostly everyone at this point. It falls into one of those two groups or possibly both of those groups. And of course, that patient I just mentioned with the alternating positive and negative home tests was fully vaccinated and boosted.
I don't know if it's worth much, but my story was the same as the guy you mentioned with symptoms, Paxlovid, horrible taste, never a fever, and then negative, but then a rebound a few days later and positive, which only lasted about 3 days.
Okay. Yeah. So, I think that is a consideration with Paxlovid. I think for patients who don't take Paxlovid, well, obviously, in an attempt to be a good neighbor and not wanting to infect anyone else, I think, and given the wide availability of test kits, it does seem reasonable to do serial testing, but I think we have to take the results a little bit with a grain of salt. And, the CDC's official position is still that, you don't have to do you don't have to test negative if your symptoms have improved and you're afebrile. That's still their official position, which was formulated at a time, I think, when there really was not adequate testing available. So I imagine they could revise it, but I'm just not sure, how to make sense of those test results. And I don't know if you have at your fingertips, read the state, the website for the state, where people can request 10 tests a month for free. But you might want to put that in the chat. And if you don't have it, I can get it here in a second. Maybe you're looking for it, but that's a good deal, and it comes very quickly.
It's frighteningly fast. I ordered them and they were here the next day.
Yeah, I think Amazon is handling
Yes.
the logistics for the state of Washington, although my first few orders came like that, and then the next order came like in 2 or 3 days, U.S. Postal Service, which is fine.
And the feds also just released that you can get 8 more tests too. So you can sign up with the feds. That just came out today. I received an email from friends that said that the feds will send you, I think it's 8 tests. It's 4 per box to each household. So I just signed up for that one too.
Okay. Well,
And we've been collecting tests here. We still have a few that we've gotten through the county, and that sayyescovidhometest.org is in the chat now.
Mm-hmm.
And do you know what the federal site is? I don't remember that one.
Want me to look for it?
Sure.
Sure.
Dr. Cowan, you didn't mention anything about long COVID. Do you have patients who are experiencing continuing symptoms or disability that may or may not be related specifically to this virus?
Well, I certainly had more earlier in the pandemic. I think fortunately, many of those people, I think have been feeling better. I haven't done any kind of scientific study of how much better or how many. Again, the official conventional wisdom is that long COVID is quite rare amongst immunized individuals. And I can't say that I'm seeing, what I would describe as long COVID. I mean, I'm certainly seeing people who feel tired and, not 100% after having Omicron, similar to what you might see after, say, influenza, but nothing like the kind of disabling, out on disability kind of symptoms that I saw pre-vaccine in young people. And yeah, it was terrible. Not really seeing new cases of that, but my practice is, I think maybe 70% of my patients are over 50. And I think I tend to have kind of a more cautious group of people who are, wearing their masks and taking precautions. Not that I'm not seeing a bunch of cases, but it's mostly in that younger cohort of my patients who are feel more free to go do maskless activities. I'm not seeing long COVID.
Which kind of gets to the final question that I have, which is, what kind of advice are you would you give about, and maybe you wouldn't, about how to live in this what obviously is a viral rich environment that we're living in, even though many of us are going to probably be able to survive if we were to get sick. how, what's the best way to negotiate this? So should we, what's your read on it?
Yeah. So, obviously I think it gets back to, individuals' tolerance for risk and kind of weighing, we're coming into a time of year when normally it would be a little warmer outside. I don't know what happened to, it seems like we had June in May. So I don't know what that means, but normally we would be having a summer, and that's a time when potentially you could do more things outside, eat outside, visit with friends outside. And while I'm no longer quite as, I used to kind of say, oh, there's no outdoor transmission. Well, now I'm not so sure. I think I have definitely seen a couple cases of outdoor transmission, although they were in circumstances where people were like exercising hard, breathing hard in close proximity, or maybe shouting at rock concerts near each other, and unmasked. But I think I still wear a mask when I go to the grocery store. Obviously, the way it really comes up is, obviously eating with other people indoors. That's the big issue, I think, for, that where, you can't really wear your mask and have dinner with other people. I did have an official dinner interviewing a potential new physician for our practice. People will be happy to know. But I actually chose to wear a mask and didn't eat at the indoor dinner. The other people who attended felt comfortable, not wearing a mask.
Right, and that's probably, we're seeing a lot of that. So that idea of personal risk.
Yeah, I think it has to do with like your medical conditions, your age, your whether you're supposed to go on vacation the next week fishing with your 85-year-old father-in-law. There's a lot of different considerations that, yeah. So I don't think there's really like a blanket recommendation. But Omicron is quite contagious, and I think now we're in the phase where it's an inconvenient truth, along with climate change.
Yeah, and I recognize, there are people who are singing in groups that are wearing masks, and there are people who are singing would be the other thing that's sort of like eating, or exercising together without masks. It's risky behavior.
Yeah, I think indoors it is, and even maybe outdoors, very, very close together. I just don't think we have any data yet. But anecdotally, I am seeing for the first time. I really basically did not see a single case of outdoor transmission, or hear about a case of outdoor transmission that I really thought was kind of, that I could really say, yeah, that really happened. That, yeah, I just didn't hear about a single one until Omicron. And of course, it's estimated to be 40 times as contagious, and that could account for the possibility that, that it could spread in an aerosol outdoors. But it would have to be in a situation, I think, where there's either very high load of virus particles, like singing, maximal exercise, Journey concert, yelling at the Kraken game, or where the airflow is maybe not as good as it should be.
Yeah, there are different kinds of settings outside. I know somebody who thinks that they were sitting outside in sort of a covered porch and they got sick, but they may not have, it may have been indoor outdoor kind of a situation.
Yeah. So, it's just, I think For patients who are at high risk, I really think they are going to continue to need to be cautious and probably not engage in some of these activities, unfortunately. But we also have to weigh the social consequences of that, and everyone, I think, will have to make their own decision, perhaps in consultation with other trusted people, maybe their healthcare provider, because there are, there are definitely psychological costs of isolation. And, I saw a patient yesterday who's younger, I think, than most of your callers. He's in his 60s. He still works, but was working remotely and basically just hasn't left his house in 2.5 years and wouldn't come in to see me until yesterday. He has diabetes. We did video chats, but I couldn't test his labs. So I think different people have different tolerance. On the other hand, I think it's really I do think it's affected his mental health, being that isolated. So, I'm encouraging people, especially now that the weather should be improving, to get out and visit with people outdoors. To me, that seems like a reasonable risk. And, you can don a mask if, it doesn't hurt, it's annoying. If the conditions seem like they're not, like a good free flow of fresh air.
Great. I really appreciate you taking the time. I want to make sure that if there's somebody here who came with a specific question, we have an option to, if you have a question for Dr. Cowan, you can open up your microphone at this point.
And I guess I should make a request that if it's a specific question about, like, I take these medications and should I take Paxlovid, that you direct that to your primary care provider in a private setting, because I think I am the primary care provider of some of the people on the call, but I would rather answer the questions off the call if it's specific like that. But if it's a more general question about, like, my grandchildren are coming to visit or something like that, yeah, for sure.
Yeah, well, that makes me think. I have a wedding and a family reunion with my 95-year-old dad coming up this summer, and he sure as heck does not want to miss either of those, and I don't think they want to miss it. So it's more a matter of trying to figure out how to minimize risk in those settings rather than forego the setting. That balance of your risk versus the consequence of missing out entirely on life.
Right. Exactly. And it's a much more reasonable risk to take now that we have the antiviral drugs, and that it looks like, the chance of serious illness post complete vaccination is low.
Karen, did you have a comment? I just saw you. I wondered if you had a comment because your mic was open.
Oh, yeah. I just wanted to mention that I've noticed lately that I'm immunocompromised. And I noticed lately that people seem, at first part, I would be wearing a mask and a lot of people wouldn't be wearing a mask. And I was getting a lot of attitude from people, and I didn't want to have to tell them why I had to wear a mask. But one thing I've noticed lately is that people don't seem to question me anymore. And that's been really nice. I mean, I don't feel like I have to constantly explain the reason why. And so that's been a real helpful for me. And I do pretty much everything online, except I walk and I go out to lunch outdoors. I was at that place where our friend got infected outdoors, but so, it's happening, but it's so rare now. And or not rare, but I think that she didn't get as sick as she probably would have if she just had Delta. And that's so comforting. So anyhow, I just wanted to say that I think the attitudes are getting better.
That's good to hear. Reed, I do see a question from Margaret in the chat. Air travel. I'm not sure if those are two different questions. I mean, I think air travel is actually surprisingly safe because the ventilation on airplanes is superior to the ventilation basically any place else any of us are likely to go. It's phenomenally good. Every place should have ventilation like an airplane. So I think actually time on the airplane itself is probably relatively low risk, especially if you're wearing a high quality mask like a KN95 or an N95. Paradoxically, it's probably one of the safest places you could be, assuming that the other people are being considerate and that you don't have like someone who tested positive that morning flying in the seat next to you. That would be unfortunate and unlucky. But aside from that, I think the airplane itself, not so worried about it. Getting to the airplane, yeah, no guarantees there. But you know, again, wearing a high quality mask, it seems quite reasonable to travel. The second part was about, can you shed virus upon arrival even if you test negative? And I'm not exactly sure, you know, I mean, certainly a single negative test, especially in the face of, say, a sore throat or other symptoms, should not be considered definitive.
Oh, go ahead.
Yeah, especially if we're talking about home tests. But, you know, as we alluded to earlier, I think that the viral shedding is, I think, maybe getting less predictable for some reason, and maybe compressed quite a bit in vaccinated people or people with some immunity already. So kind of catching the virus shedding with a test, I think, can be quite tricky, even a PCR test, because obviously it's, you know, if there's no virus there, it's not going to be positive. The antigen test, I think that's much less accurate and much less sensitive. And so a negative antigen test, I would say, carries much less weight. Negative PCR means there was no living or dead virus particles, you know, in the swab at the time it was collected. The antigen, you can't say that. The home test, you can't say that.
Okay. Yeah, I had a question. I have severe spring allergies, lucky us, huh? Many of us. And is there one defining thing about Omicron? You know, because I feel like sore throat, you know, the burning eyes, the just kind of feeling yucky. And I'm thinking, okay. And I have to say, I've taken several tests at home to check because they did feel really yucky.
I think in the setting where you're able to get this, you know, ample supply of home tests, I would just say, you know, test out of an abundance of caution and consideration for your neighbors. But no, I don't think anymore. With earlier variants, especially Delta, you know, loss of taste and smell was really quite common and pretty diagnostic. That does not appear to be the case with Omicron. And of course, there are many asymptomatic cases of Omicron subvariants.
Yeah. Oh, well.
Thank you, Dr. Cowan, for spending the time with us. This has been very informative, and I have a better perspective thanks to your sharing your experience and study.
And you too, Reed. I think your questions were really reflected a lot of thought and doing your homework. So I'm impressed with your questions, as always.